Dear colleagues, it's a great honor for me to share with you today what I think are important lessons learned from 3 large prospective precision medicine clinical trials, TAILORX, MINDACT, and RxPONDER. Here you can see my disclosures. Please note that I have no conflict in relation with the companies that are marketing gene expression signatures. As medical oncologists, we have a huge responsibility when it comes to the selection of the best adjuvant systemic therapy for our breast cancer patients. And of course, in this difficult task, we welcome prognostic biomarkers, which are indicating which patients are at high risk of relapse. But we also welcome predictive biomarkers, which are going to tell us which is the treatment that we will really help our patients. In the last 15 years, 5 gene expression signatures have entered the mainstream of the treatment of early breast cancer, namely the breast cancer index, EndoPredict, Prosigna, or PAM50, Oncotype DX, and MammaPrint. These signatures are mainly used today to help with treatment decision-making in hormone receptor positive HER2 negative breast cancer, because it's for this particular patient group that they have shown to bring prognostic information beyond the standard clinical pathological factors. Now, there have been 4 large clinical trials designed to demonstrate the clinical utility of 3 of these signatures. For Oncotype, the clinical trials are TAILORX and RxPONDER. For MammaPrint, it's the MINDACT trial. And finally, for PAM50, it's the OPTIMA study, which is still recruiting patients. Today, we are going to discuss very interesting results from RxPONDER, TAILORX, and MINDACT. What I've done here is a summary of the design of these important trials. Let us start with the most recent one that was presented at the San Antonio Breast Cancer Conference last December for the first time, RxPONDER. So RxPONDER focused on a high-risk clinical population, namely women with 1 to 3 positive nodes and luminal breast cancer. These patients, 5,015 women, were randomized to receive endocrine treatment alone or chemotherapy plus endocrine therapy. RxPONDER nicely complements TAILORX. TAILORX indeed randomized women with node negative breast cancer and a mid-range recurrence score going from 11 to 25 to receive endocrine treatment alone or chemotherapy plus endocrine treatment. And you see that about 6,711 such women were randomized. If the women showed a low recurrence score and were node negative, they were treated with endocrine treatment alone. In contrast, if they had a high recurrence score, above 25, they all received chemotherapy plus endocrine therapy. I forgot to tell you that RxPONDER selected patients with a recurrence score ranging from 0 up to 25. Now let us come to the MINDACT trial, which obviously looked at another gene expression signature, the 70 gene signature MammaPrint. This trial enrolled patients with node negative, but also node positive disease. As you can see, 21% of patients in MINDACT had 1 to 3 positive nodes. These patients largely had luminal disease, but there were a few patients also with HER2 positive breast cancer and triple negative breast cancer. MINDACT is the only of the 3 studies that stratified patients according to their clinical risk, calculated using adjuvant online, and their genomic risk, namely the MammaPrint signature. The patients who had discordant risk, so for example, a clinical high risk but a genomic low risk, or a clinical low risk and a genomic high risk, those are the patients in MINDACT who were randomized to receive either endocrine treatment alone or chemotherapy plus endocrine therapy. Today, we are only going to discuss the results obtained in women considered at high clinical risk in the 3 trials. Obviously, in RxPONDER, with all women having 1 to 3 positive nodes, we can consider that the 5,000 patients are all clinical high risk. In MINDACT, as you can see from the diagram, we have 1,551 women at clinical high risk, but at low genomic risk. Finally, in TAILORX, it's important to realize that there were a lot of patients in this trial at low clinical risk, but Dr. Sparano did the exercise of reclassifying these patients according to their clinical risk using the MINDACT definition. And as you can see on the diagram, we end up here with 1,697 women among those randomized who were at clinical high risk. Now, we are going to dissect the results of these 3 trials because it is fascinating to realize that they reinforce each other. And as we will see, we now have very robust data indicating that at least some patients can be spared chemotherapy administration if we order one of these genomic tests. So the data that we are going to discuss together are based on the first presentation of the results of RxPONDER at San Antonio 2020. I will also use data that have been published by Dr. Sparano in the New England Journal of Medicine. And for MINDACT, I'm going to use the mature results of this trial, which will appear in Lancet Oncology in February or March. So let us compare these trials in terms of patient population, primary endpoints, hypothesis, and whether they succeeded in demonstrating their primary hypothesis. So RxPONDER is a trial that started in 2011 and concluded recruitment in 2015. So it's clearly the trial with the shortest follow-up. The follow-up is 5 years. You see that the primary endpoint is invasive disease-free survival. The primary hypothesis was that there would be a positive interaction between chemotherapy benefits and increasing recurrence score. In terms of results, this trial failed to demonstrate this primary hypothesis, but it could demonstrate a benefit from chemotherapy addition to endocrine therapy in the entire patient population. Additionally, as we will see in a few minutes, it found an interaction between chemotherapy benefit and menopausal status. MINDACT and TAILORX are older studies. TAILORX started in 2006, and MINDACT in 2007. TAILORX was a very large study with the recruitment of close to 10,000 patients, all node negative. And MINDACT, as we already said, was also a large trial, 6,693 patients, close to 80% being node negative. The primary endpoint for TAILORX was invasive disease-free survival, while for MINDACT, it was distant metastasis-free survival. And you see that these two large studies have a median follow-up of around 9 years. The primary hypothesis of TAILORX was to demonstrate that endocrine treatment is non-inferior to chemotherapy plus endocrine treatment in case of a mid-range recurrence score. And indeed, the trial was successful. As you can see, the hazard ratio for invasive disease-free survival was close to 1, with the 95% confidence interval shown here, and the upper limit of this 95% confidence interval was 1.24, and this was indeed inferior to the margin that had been fixed in this trial, which was 1.32. For MINDACT, the primary hypothesis was that women considered at high clinical risk, but showing a low-risk mammapyrin signature, that these women should have a 5-year distant metastasis-free survival in excess of 92%. And indeed, this has been verified first with a median follow-up of 5 years. This was the publication in 2016 in the New England, but the updated results of MINDACT continue to show that the primary hypothesis is verified. You see that the 5-year distant metastasis-free survival for this critical group of patients is 95%, with a 95% confidence interval ranging from 93.1 to 96.6. And here again, you see that the lower limit of this 95% confidence interval is indeed above the margin that was selected, which was 92%. Now let's go in more details about the RxPONDER study that we discovered in San Antonio. So what you see here is invasive disease-free survival in the entire patient population by treatment arm, indicating a benefit from the addition of chemotherapy to endocrine therapy, but of small magnitude. The benefit is 1.4%. The hazard ratio is indicated here, it's 0.81, and the difference is statistically significant. Please note that this first analysis of RxPONDER occurs after the observation of about 54% of the expected IDFS events that have been required for the final analysis. So it is the first presentation for this trial. We will have more mature data presented to us in the future. What is really quite striking in RxPONDER is to realize that for postmenopausal women, there is absolutely no indication of any chemotherapy benefit at this median follow-up of 5 years. The hazard ratio is 0.97, and you see here a confidence interval. So clearly no statistical significant difference in invasive disease-free survival, which is in sharp contrast with what is seen in the premenopausal women. Here we see an absolute difference of slightly over 5% and a hazard ratio of 0.54. So more details is given here in terms of type of relapses. And what you can see is that most of the relapses seen were distant relapses. If we now look at the forest plots for the postmenopausal women, what we can see here is that there is not a single subgroup that appears to benefit from chemotherapy. Overall, you see here, the hazard ratio is very close to 1. If we now go to the forest plot for the premenopausal women, we see overall this quite significant benefit from the addition of chemotherapy. And again, it appears that all the subgroups derive a benefit. I want to point your attention only on the age effect. It could well be that the benefit of chemotherapy is slightly less pronounced when the women are 50 years or older. What is also quite surprising in RxPONDER is that there is no indication of a smaller benefit from chemotherapy for the very low values of the recurrence score. So recurrence score 0 to 13, you see clearly the chemo benefit. Recurrence score 14 to 25, the same benefit. So why is it that RxPONDER failed to show an increasing chemotherapy benefit with an increasing recurrence score? This was the initial hypothesis. And here I would like to encourage you to read this publication in JCO 2020, where the authors, including Mitch Dowsett, have analyzed the molecular drivers of the oncotype gene expression signatures. And what you see here is, in fact, that when we deal with these low values of the recurrence score, it is the estrogen module that appears to dominate in the signature. The proliferation module is not dominating in these low range of recurrence score values. It starts to become important for the higher range values. In addition, what I didn't know, but it's important to tell that, is that there is a threshold on the proliferation module in the calculation of the recurrence score. So these data make me think that perhaps we have indirect support here for, in fact, an endocrine effect of chemotherapy rather than a direct cytotoxic effect. Finally, I want to stress the fact, this is very important, is that RxPONDER, which is a large study, well-powered, already shows a small but statistically significant overall survival improvement with the addition of chemotherapy to endocrine therapy in the premenopausal subgroup. So the conclusions of Dr. Kalinski in his presentation at San Antonio are the following. At this interim analysis with 54% of anticipated IDFS event in the overall population, the oncotype recurrence score between 0 and 25 was prognostic, but it did not show a treatment interaction with chemotherapy. The relative benefit of chemotherapy was similar across all the values of the recurrence score between 0 and 25. Postmenopausal women with this recurrence score 0 to 25 and 1 to 3 positive nodes did not benefit from adjuvant chemotherapy in any subgroup. In contrast, premenopausal women had a clear benefit from the addition of chemotherapy to endocrine therapy. A 46% relative decrease in IDFS events observed across all the subgroups, and a 53% relative decrease in deaths, leading to a 5-year overall survival absolute improvement of 1.3%. Additional follow-up is ongoing, of course. Now, what I would like to do with you is to look a little bit closer into the age effect across the 3 trials, because I think that the results of these 3 studies reinforce one another. Here again, we see the differences between the trials. So the chemotherapy benefit, and this is important to stress, was the primary endpoint in TAILORX, a kind of sub-primary endpoint in RxPONDER, but it was a secondary endpoint in MINDACT. So MINDACT has less statistical power compared to the other trials for the question of the chemo benefit. For the population tested, you see that we have more women aged 50 years or more than younger women. In TAILORX, we are at the end of the day dealing with 517 young women, clinical high risk. in MINDACT, we are dealing with 535 young women clinical high risk. And in RxPONDER, all the premenopausal patients are, of course, considered clinical high risk. There are also differences in the chemotherapy used in these trials. And what we see is an important use of the TC regimen in the US. TC is docetaxel cyclophosphamide. You see that oncologists like this regimen. It is used in over 50% of patients in TAILORX and RxPONDER. It is less used in MINDACT, and MINDACT has a relatively high prescription rate of anthracycline with or without taxane-based chemotherapy regimens. Non-adherence to randomized therapy, of course, happens in these trials, and you can see that it occurred in 5 to 12, 13% of patients in the 3 studies. And finally, in terms of endocrine therapy, we have to stress that it's only a relatively small proportion of young patients who were offered ovarian function suppression. 13% in TAILORX, 20% in MINDACT, 16% in RxPONDER. And here is what I consider the really interesting observation. What we see in the 3 trials, if we focus only on women at high clinical risk, but showing a low risk genomic signature, what we can see is first that in the older women, chemotherapy, these are the blue circles, doesn't bring any benefit. And this is a consistent finding across the 3 trials. In contrast, in the younger women, what we see, the red circles, is a chemotherapy benefit. And again, the treatment effect is very reproducible from one study to the other with a hazard ratio of 0.54 or 0.57. And this reduction in risk translates into important absolute improvements. So in TAILORX, where the primary endpoint is distant recurrence at 9 years, you see a 6% absolute benefit for the addition of chemotherapy. In MINDACT, where the primary endpoint is distant metastasis-free survival at 8 years, you see a 5% benefit for the addition of chemotherapy. And finally, in RxPONDER, where the primary endpoint is invasive disease-free survival, you again see a chemotherapy benefit in absolute terms of about 5%. The critical question, of course, is, could an ovarian function suppression effect explain the chemotherapy benefit in these younger women with low-risk gene expression signatures? It's clearly a reasonable hypothesis, but we cannot be 100% sure. In TAILORX, this particular graph is highly suggestive. What you see here is that in these young women with a recurrence score ranging from 16 to 25, the chemotherapy benefit is not very evident in the very young women, those in whom chemotherapy is unlikely to induce ovarian function suppression. And it becomes more visible in women 41 to 45 years of age and women 46 to 50 years of age. On the other hand, we have also learned through the conduct of the important soft and text trials in young women that fine-tuning endocrine treatment, in particular reinforcing endocrine treatment with ovarian function suppression, can lead to marked improvements in distant recurrence-free survival of up to 10%, for example, if we use ovarian function suppression together with an aromatase inhibitor. So this is an interesting question, and we can, of course, debate for hours, but what the message that is emerging now from these trials is that we need, in the coming years, to do more research for young women with breast cancer, and there are a lot of young women with breast cancer in Egypt. It is very disappointing when you look in the literature to see that we do not have very good data on the rate of amenorrhea induced by our chemotherapy or preferred adjuvant chemotherapy regimens. This is a publication by Patricia Gans in JCO in 2011, where at least we find some data in the first 2 years following chemotherapy, indicating that up to 80% of women will develop amenorrhea if we use the AC taxane strong adjuvant chemotherapy regimen, and where we do not see important rates of amenorrhea is mainly when we use regimens like AT, so anthracycline taxate, without cyclophosphamide. Another consideration that we will have to put in perspective if we initiate further studies for young women with early breast cancer is, at the end of the day, what is best for their quality of life. And I want here to draw your attention to this CANTO trial conducted in France. It is a real-world data analysis of women treated with adjuvant chemotherapy or endocrine therapy. And in these women, quality of life has been studied. And what is striking to me is this orange line here. It represents quality of life with endocrine adjuvant therapy. And it clearly shows a decline with a worsening continuing beyond 1 year. In contrast, if you give adjuvant chemotherapy, you see a very sharp decrease in quality of life in the first 12 months, but then you see a rather quick recovery. And this blue dotted line refers to the use of chemotherapy plus endocrine therapy. So at the end of the day, it will be really important when we compare different strategies for young patients to examine patient-reported outcomes in the years following the administration of adjuvant systemic treatment. So let me now conclude and discuss what am I going to advise my patients in my clinic on next Monday. If my preferred gene expression signature is oncotype, this is what I think should be the treatment algorithm on Monday. If the recurrence score turns out to be 26 or higher, the patient has 0 or 1 to 3 positive nodes, it doesn't matter. Here we are in a clear scenario where adjuvant chemotherapy is currently recommended, independently from menopausal status or nodal status. If we now focus on women who have this low recurrence score or mid-range recurrence score, and you see that 2/3 of patients will end up with the mid-range recurrence score. Here, the situation is now very clear for postmenopausal women, independently from nodal status, whether they are node negative or they have 1 to 3 positive nodes. We have now robust data indicating no chemotherapy benefit. In the premenopausal women, the situation is a little bit more complex. If they are node positive, like in all the patients in RxPONDER, you see that chemotherapy is recommended in principle. If they are node negative and low clinical risk, you don't need to recommend chemotherapy. But if they are high clinical risk, then starting at a recurrence score of 16 and up to 25, chemotherapy should be discussed. Of course, for patients who are not at all ready to accept chemotherapy, I think it's reasonable to discuss an alternative, and the alternative normally should be ovarian function suppression plus an aromatase inhibitor. Now, if your preferred gene expression signature is MammaPrint, here is what I think you should recommend to your patient. So, if the patient has a high-risk MammaPrint signature, what you will have to recommend depend on clinical risk. For the high clinical risk patients, independently from menopausal status, you should recommend chemotherapy. If the patient is low clinical risk and has a high risk MammaPrint signature, we will see in a minute that there is some weak indication that these patients could benefit from chemotherapy, but the data there, unfortunately, are inconclusive. I will show them to you in a second. However, what we can see is that for a low-risk MammaPrint signature, the decision for postmenopausal women is straightforward. Whether they are at low clinical risk or high clinical risk, they do not need chemotherapy. In contrast, for the young premenopausal women, if they turn out to be at low clinical risk, you can spare them chemotherapy. But if they are at high clinical risk, chemotherapy is to be recommended, or as an alternative, but with some uncertainty, of iron function suppression and an aromatase inhibitor. I just want briefly to show you other interesting data coming from San Antonio 2020, presented by Dr. Van het Veer. She focused on the MINDACT results in the clinical low-risk patients. So in MINDACT, you could be clinical low risk and genomic low risk, or you could be clinical low risk and genomic high risk. We have a very high proportion of women low risk by both tests, both methods, more than 2,700. And what we see with a median follow-up close to 9 years is that indeed these patients do very well without chemotherapy. But here we have a group for which things are a little bit uncertain because of the size of this group. We have only 593 patients, clinical low risk and genomic high risk. And at close to 9 years of follow-up, in fact, what we see is the suggestion of a possible chemotherapy benefit. You see the hazard ratio is 0.85, but unfortunately, the 95% confidence interval is large, meaning that we cannot be sure that chemotherapy is helping these women. So the most important take-home message from these 3 large precision medicine clinical trials is that for patients who have luminal breast cancer, are at high clinical risk up to 2 or 3 positive nodes, no more, but will show a low genomic risk signature, either Oncotype DX or MammaPrint. We now have some very robust and consistent data indicating that we should not recommend adjuvant chemotherapy for postmenopausal women. This is not the case, as I showed you, for the young women. And here we clearly need more investigations to be done in the coming years. And this will be very important in countries where breast cancer affects a lot of young women. Thank you very much for your attention.